Welcome to the first morning session of the Meet the Expert. It will be about bone and calcium disorders. Um, we're a little bit late, so we'll start right away. Our first speaker is Dr. John Ayuk from the UK. He's a consultant endocrinologist and pituitary service co-lead in University Hospital at Birmingham. Our first talk will be about hyperparathyroidism update, and I believe we have it recorded.
Good morning, ladies and gentlemen. I would like to start by taking the opportunity to thank the BDER Conference Organizing Committee for inviting me to deliver this talk on hyperparathyroidism. It is an honor to be talking to you, and I do hope in future I have the opportunity to come over and do so in person. These are my declarations of interest, and I can confirm they do not in any way pertain to this talk. Let's start by looking at a simple overview of calcium homeostasis, which I'm sure you all know. So PTH is secreted by the parathyroid gland, and in the kidney it converts 25-hydroxyvitamin D to 1,25-hydroxyvitamin D, which leads to increased calcium absorption in the gut. In the kidneys, PTH also leads to increased calcium reabsorption from the urinary filtrate, and it does the same in bone. We generally talk about three forms of hyperparathyroidism. First of all, there's primary hyperparathyroidism, which is usually caused by a benign parathyroid tumor and causes hypercalcemia with low 7-phosphate. Then we have secondary hyperparathyroidism, which is outside the remit of this talk, but is usually caused by long-standing renal disease and vitamin D deficiency. And finally, we have tertiary hyperparathyroidism, which is caused by long-standing secondary hyperparathyroidism and leads to irreversible parathyroid hyperplasia. This is usually found in the context of chronic renal disease. Primary hyperparathyroidism is caused by increased secretion of parathyroid hormone from one or more parathyroid tumors. These are usually single benign adenomas, but in 15 to 20% of cases, you can have multi-gland disease. It's the most common endocrine condition and the most common cause of hypercalcemia. In most cases, it is sporadic, but in a few cases can have a genetic basis. There is a female preponderance of around 4:1. The worldwide prevalence of PTHP is thought to be around 0.84 to 0.86%, and the peak incidence is in the early menopausal years. Over the years, the clinical presentation and phenotype of primary hyperparathyroidism has changed. Previously, most patients presented after they developed symptoms of PHPT, and this generally involved the kidneys and the skeletal system and included things like kidney stones, nephrocalcinosis, bone abnormalities. More recently, hypercalcemia is detected through biochemical screening in patients who present with non-specific symptoms, and therefore in many countries, certainly in the Western world, this is discovered before there are any clinical manifestations. And more recently, we've discovered the phenomenon of normal calcemic primary hyperparathyroidism, which is generally diagnosed when PTH is measured in patients who are being screened for causes of osteoporosis. And to make the diagnosis, all other secondary causes of hyperparathyroidism need to be ruled out. The most common clinical manifestations of PHPT involve the kidneys and the skeletal system. In the kidneys, patients will present with kidney stones, nephrocalcinosis, which is often asymptomatic, and reduced kidney function. This can also occur in patients with asymptomatic PHPT. In the skeleton, PHPT tends to lead to low bone density with fragility fractures, skeletal deformities, and bone pain. And there's a typical finding which is generally seen with prolonged disease of osteitis fibrosa cystica. Neuromuscular manifestations are nowadays less prominent, and tend to present with patients tend to present with muscle weakness, gait disturbances, and muscle atrophy. This only occurs in symptomatic patients, and so we are seeing it less and less these days. Other features seen in PHPT include neurocognitive features, which are general features like fatigue, anxiety, cognitive decline. Many patients will complain of forgetfulness, poor concentration, and will tell you it has a significant impact on the quality of life. But these are features which are common with very many chronic diseases, so it's quite difficult to usually say to patients, we are certain that these symptoms you're experiencing are due to PHPT. And usually what we tell patients is, look, these symptoms may be due to PHPT, but they may not. And we're only going to know if you have an operation, your calcium normalizes, then whichever symptoms have gone away, we will know we're due to the PHPT. Cardiovascular abnormalities are also now, less frequently seen because patients are diagnosed earlier, and other clinical manifestations like peptic ulcer disease, pancreatitis, gout, pseudogout are becoming rarer and rarer, and certainly do not tend to present in patients with asymptomatic disease. So how is the diagnosis of PHPT made? Generally, what one would find is a high or normal PTH level in the presence of hypercalcemia. If the PTH level is low in the presence of hypercalcemia, then other causes need to be sought. Other tests which need to be done when you suspect a patient of having PHPT include phosphate and vitamin D levels, and also 24-hour urine calcium and creatinine. The next few slides will look at recommendations from the International PHPT Workshop. In patients with PHPT, the assessment should include biochemical, skeletal, and renal evaluation. For the biochemical evaluation, we should measure total serum calcium, or total adjusted serum calcium, or ionized calcium if we're considering normal calcemic PHPT, phosphate, intact PTH, vitamin D, and creatinine. Skeletal evaluation involves a 3-site DEXA scan, looking at the lumbar spine, hips, and distal third of the radius, imaging for vertebral fractures, which could include, or which could be done either by vertebral fracture assessment on DEXA scanning or with vertebral X-rays. In addition, if it's available, trabecular bone score can also be undertaken. And finally, for the renal evaluation, one needs to assess the eGFR, or preferably creatinine clearance, 24-hour urine collection for urinary calcium, and imaging for kidney stones or nephrocalcinosis. And now a few words to normal calcemic primary hyperparathyroidism. This can be associated with low BMD and kidney stones, so it is not as benign a condition as some like to make out. It can be asymptomatic, but many patients with this condition will present with symptoms. And it's diagnosed by demonstrating elevated parathyroid hormone with persistently normal serum-adjusted total calcium and ionized calcium. In order to make the diagnosis, all other potential causes of hyperparathyroidism, particularly secondary hyperparathyroidism, need to be excluded. And these include things like vitamin D deficiency, renal insufficiency, primary calciuria, hypercalciuria, malabsorption syndromes, and certain medications. And now back to the International Workshop recommendations. Surgery is the only definitive treatment option for PHPT, and the panel recommends parathyroid surgery in all patients who have symptomatic PHPT, unless it is medically contraindicated. Obviously, there may be other circumstances under which patients with symptomatic PHPT do not undergo surgery, and this may well be due to the patient's wishes. In patients with asymptomatic PHPT, there are certain criteria which we look at to determine whether these patients should be put forward for parathyroid surgery or not. So first of all, there's the absolute level of the serum calcium. If it's greater than 1 milligrams per deciliter above the upper limit of normal, then this is an indication for recommending surgery, even if the patient is not symptomatic. And looking at skeletal involvement, so patients who've had a fracture picked up either by vertebral fracture assessment or vertebral x-ray, or patients with bone mineral density T-scores of less than minus 2.5 at any site will be eligible for surgery. In addition, patients who have EGFR or creatinine clearance less than 60 milliliters per minute, or have evidence of kidney stones or nephrocalcinosis on X-ray, ultrasound, or any other imaging modality, or patients with high urinary calcium excretion. These patients will also be, surgery will also be recommended for these patients, even if they are asymptomatic. Age under 50 is another criterion that the International Workshop Panel recommended, although this is one which is probably not necessarily adhered to as strictly, because patients who are 55, 60, nowadays with life expectancies are expected to live many years with the condition, and so in such cases it may be reasonable to offer parathyroid surgery to these patients. And even if none of these criteria are met, there will always be a discussion between the physician and the patient, and it may well be that in some patients, even with none of these criteria met, they go forward for parathyroid surgery. Now, PHPT is often considered a relatively benign condition, and one may well ask, well, if I've got a patient with PHPT who is asymptomatic, feeling well and getting on with their lives, do I really need to recommend them for surgery? Now, before we take that stance, it is worthwhile looking at the natural history of PHPT. In this study, it was done by looking at bone mineral density T-scores at various sites: the lumbar spine, the femoral neck, the distal third of the radius, and the ultradistal radius. Now, in these charts on the left, the solid red line represents the group of patients who underwent parathyroid surgery, and the dotted blue lines represent the patients in the observation group. Now, the dots in the middle of those lines represent the 5-year mark, and the end of the dots at the end, the 10-year mark. And as you can see, in virtually all of these sites, there is a divergence between the bone mineral density T-scores between the patients in the observation group and those who underwent parathyroidectomy. And those in the observation group tend to have lower bone mineral densities at 5 years and 10 years than those who underwent parathyroidectomy. So this shows the disease is not as benign as we sometimes think. As I mentioned earlier, surgery is the only definitive treatment option for PHPT, and in high volume centers with experienced surgeons, the remission rates are consistently above 95%. Preoperative localization is more common now than the traditional foreground exploration, and most centers use a combination of ultrasound scanning and sestamibi scanning because it's sensitive and cost-effective and will pick up most parathyroid adenomas. In cases where further imaging is required, nowadays 4-dimensional CT scanning is being undertaken, and further scanning in the form of fluorocholine PET-CT scanning is also being done, but this is still not as widely available as the other modes of imaging. Surgeons also have other intraoperative aids, which include frozen section, where a section of the excised tumor is sent to the laboratories to have a look to confirm it is indeed the adenoma. Intraoperative PTH measurements, where following parathyroidectomy, the surgeons will send a blood sample for parathyroid hormone, or will do an on-site sample for parathyroid hormone levels and expect a 50% drop if the adenoma has been removed, And other aids include things like methylene blue and indocyanine green angiography. What is very important to note is that negative imaging is not a contraindication to parathyroidectomy. And even with negative imaging, if biochemically the disease has been confirmed, then the surgeons will go in and do foreground exploration and explore elsewhere for ectopic disease. Earlier, I mentioned the high surgical remission rates when parathyroid surgery is undertaken in high volume centers with experienced surgeons. This concept is supported by the positional statement of the European Society of Endocrine Surgeons, and I've taken a few points from this positional statement and on this slide. I don't want you to read all of it, but just look at the phrases in red. So if we look at the first question, is there any correlation between caseload and outcomes? And the suggestion is high volume settings unequivocally achieve better clinical and economic results. The second question, how can high and low volume parathyroid surgeons be defined? And the consensus they came to was a high volume surgeon will be undertaking 40 parathyroidectomies or more annually, and a low volume surgeon will be undertaking 15 procedures or less. And final question, should parathyroid surgery be concentrated in high volume settings? And equivocally, they suggest that that should be the case, and because those are the centers which have the greatest expertise. So how about patients who are not able to undergo parathyroidectomy for any reason, or patients who have a diagnosis of PHPT but are asymptomatic and do not fulfill any of the criteria which are generally required for surgery? How are these patients managed? Now, some patients can be managed medically, although we do need to note there is actually no medical treatment for PHPT. What we will be aiming for in managing these patients is to lower the calcium level, especially if the patient is symptomatic, or to manage the reduced bone mineral density, or both. Now, we know from evidence from systematic reviews that in patients with PHPT, various forms of treatment will improve bone mineral density, including the bisphosphonates, denosumab, vitamin D, and estrogen. Cinacalcet, we know, will reduce the calcium levels and the PTH levels in these patients, but not have a significant impact on bone mineral density. So the recommendations from the international workshop are that in patients who do not undergo surgery, the pharmacological treatment should be used for these specific indications. In patients with low BMD, we should use bisphosphonates or denosumab, and in patients with serum calcium levels above 1 milligram per deciliter or 0.25 millimoles per liter, above the upper limit of normal, who do not undergo parathyroidectomy, these patients can be managed with cinacalcet. Although the evidence around this is not very strong, and it tends to be used in patients who are particularly symptomatic. Patients who are vitamin D deficient with PHPT should always have their vitamin D replaced. So I'd now like to look at a couple of specific circumstances, starting with the management of PHPT in pregnancy. Now, this can be really taxing and quite difficult because one's dealing not just with the mother, but also with the baby. Now, mild cases can be managed with hydration and monitoring of calcium levels, but in many cases, the actual pregnancy seems to worsen and to significantly exacerbate hypercalcemia. Certainly, bisphosphonates and denosumab should not be used because of concerns about the impact on fetal bones. Data are very limited for the use of cinacalcet, but there are case reports of use of cinacalcet in pregnant women with PHPT, and indeed at our center we have used it on a couple of occasions in patients with severe PHPT where we have felt we would like to try and delay having surgery till after delivery. Surgery is generally considered in the second trimester for patients with calcium levels above 1 milligram per deciliter above the upper limit of normal, and in whom surgery is not contraindicated. Imaging should be limited to ultrasound for obvious reasons. And if surgery is deferred, then the neonate should be monitored closely for hypocalcemia. If surgery is deferred, then obviously following delivery, one would like to undertake surgery as soon as is feasibly possible, and certainly before the next pregnancy. I would also like to talk briefly about the management of syndromic primary hyperparathyroidism. The context in which we see this most frequently is with multiple endocrine neoplasia type 1. Obviously, because in these patients, all 4 glands have the propensity to be involved and present with hyperplasia, there is a high risk of persistent or recurrent PHPT or chronic hypoparathyroidism following parathyroidectomy. There remains a lot of debate around the timing of surgery, and we certainly do not tend to rush in to operate early on because many of these patients will develop primary hyperparathyroidism in their late teens or early 20s. And the earlier one intervenes, the more likely one is to require to need to operate again in the future. The surgical strategy obviously will differ from patients with sporadic PHPT, because with sporadic PHPT, most patients will have a single adenoma, and which can be removed. But in patients with MEN1, one would not normally go in and remove a single gland, because obviously all the other glands are likely to become affected later. And as you know, neck surgeons do not like going back into scar tissue following surgery. So the strategies which tend to be used, the surgical strategies for patients with MEN1 include subtotal parathyroidectomy, a total parathyroidectomy with auto-transplantation of a piece of parathyroid tissue, or unilateral clearance on the understanding that if the patient has a recurrence, at least one side of the neck is untouched. Surgeons also are more prone to using intraoperative aids in patients with MEN1 because it tends to be crucial to ensure that the surgery has been successful in lowering the parathyroid hormone levels. So intraoperative PTH is something which is used in many of the large centers which undertake surgery in patients with MEN1. And a newer sort of aid is parathyroid autofluorescence. But again, that's not really in widespread use. Now, in the last few minutes, I'd like to talk a little bit about tertiary hyperparathyroidism. Now, tertiary hyperparathyroidism is challenging. And the very first challenge is, what is it? What is the definition of tertiary hyperparathyroidism? And there is still debate around that. It starts to occur when excess PTH is secreted by the parathyroid glands, usually after long-standing secondary hyperparathyroidism. The context in which we see it most often is in patients with long-standing chronic kidney disease. Some authorities actually will only reserve that term, tertiary hyperparathyroidism, for patients in whom the hyperparathyroidism persists after the patients have had a successful renal transplant. The pathophysiology behind tertiary hyperparathyroidism is prolonged stimulation of parathyroid cells, which results in nodular hyperplasia. Generally, we see polyclonal hyperplasia of all 4 glands. However, it is possible to find monoclonal parathyroid adenomas in this setting. The mechanism underlying this are not well understood, and these patients may just have 1 or 2 adenomas with the remaining glands normal. The clinical manifestations of tertiary hyperparathyroidism include worsening renal osteodystrophy with bone mineral loss and increased fracture rates, poorer graft outcomes due to renal vasoconstriction and tubular interstitial calcification, which can lead to graft loss, and worsening cardiovascular outcomes with significant vascular events and increased mortality. The indications for parathyroidectomy in tertiary hyperparathyroidism are persistent hypercalcemia despite medical management, increased alkaline phosphatase, which indicates high bone turnover, and long-term complications of PHPT, which include osteoporosis, kidney stones, bone pain, etc. The outcomes from parathyroidectomy are actually superior to medical treatments and like calcium mimetics when you look at calcium levels, parathyroid hormone levels, and femoral neck bone mineral density. The surgical techniques generally involve subtotal parathyroidectomy or total parathyroidectomy with or without autotransplant. And again, with these patients, sometimes surgeons will use intraoperative PTH monitoring or pre-surgical imaging. But there is debate around how useful these aids are. So this brings me to the end of the talk. And just to summarize, PHPT is one of the most common endocrine conditions and the most common cause of hypercalcemia. When diagnosing normal calcemic PHPT, secondary causes of hyperparathyroidism need to be ruled out. Parathyroidectomy is recommended in all symptomatic patients unless there's a reason the patient cannot undergo surgery. Parathyroidectomy is also recommended for asymptomatic patients with evidence of end organ damage. Surgery should be undertaken in high volume centers with experienced surgeons, and special considerations need to be taken for patients when undertaking surgery for syndromic PHPT. Thank you very much for listening, and I'm happy to take any questions.